Thanks for giving me an opportunity to discuss this, which crosscuts a few of the sessions that I participated in at the AED. So isotretinoin, also known as Accutane, is an incredibly important medicine in the management of acne. It's one of the few medications, maybe the only one that can cause a lasting clearance of acne. And for those who have very severe or scarring acne, it's one of the most effective treatments that we have. However, it's not without limitations, and one of them has been the potential concerns around liver enzyme testing and triglyceride and lipid monitoring people's blood cholesterol and their blood triglycerides. And so there have been a lot of discussion and questioning about how should we monitor this medicine, and even should we monitor it? And so in several of these sessions, we discuss some of our research on this topic, where we look at the potential value of lab monitoring for isotretinoin. And two of the key take-home points here is when we look at liver function testing, patients are just as likely to have abnormalities before they start the medication as on treatment, and really truly high abnormalities don't seem to occur. And so when you put those two things together, it suggests that a lot of what we're seeing is just background noise. It's lab abnormalities that aren't related to the medication, and it doesn't seem like patients really develop truly meaningful liver injury. They may have some mild LFT changes, but true liver injury doesn't seem to occur. And that's been true in other larger studies as well. And so that really calls into question the value of LFT, of liver function test monitoring. Now, when we look at lipid testing, we certainly see that patients on isotretinoin, their cholesterol and triglycerides rise during treatment. They usually stabilize after a couple of months, typically when people get on a stable dose at that time. And really high abnormalities, for instance, triglyceride abnormalities over 500 are very uncommon. They're in less than 1% of people that we treat with isotretinoin, but not zero. Now, interestingly, we want to check triglycerides to try to prevent pancreatitis. At least that's what a lot of the stated rationale for it is. And when we look at patients who get pancreatitis on isotretinoin, first, it's exceedingly rare. And then those who do often don't have elevated triglycerides. So if we're checking triglycerides to try to prevent pancreatitis, it may actually not be an effective strategy in the first place. And so this work that we discussed in a few of the sessions kind of calls into question the value of this monitoring. Now, we've also conducted a Delphi recently, which suggested just checking labs at baseline and peak dose. And if those are normal or relatively unremarkable and otherwise healthy individuals, no further monitoring is necessary. And that's really started to be incorporated into the new guidelines for acne that were just released. But I would posit even further that for those who really want to avoid lab monitoring for various reasons, that after a discussion of the risks and benefits, it's reasonable to consider very limited monitoring in these patients. And that's something that we discussed in the controversies in acne and rosacea session. So when we think about lab monitoring, really in general, the goal should be either to guide dosing to figure out what dose of a medicine a patient needs, like we think about that with vancomycin, or to avoid side effects, to be able to identify someone who's at risk of a problem and stop that before it occurs. So if we're not doing either of those things, and I'd say in the case of isotretinoin, it's questionable if we're doing either of those things, then the lab monitoring has limited usefulness. Now, on the cost side of it, there's of course the direct cost. So the labs that we order for isotretinoin, just to go from where we are right now to that checking at baseline and peak dose would save about $100 million annually in the United States of lab costs for patients. And as people have more and more high deductible plans, they're paying those costs. So these costs are not insignificant financially, but there's also a psychological cost of lab monitoring. When a medicine needs lab monitoring, that to patient says, this medicine's dangerous. You've got to monitor it because it's scary. And it makes people afraid of the medicine, potentially for the wrong reasons. Additionally, some patients just don't like getting their blood drawn. It's uncomfortable. Some people faint. So there are also those costs to lab monitoring as well from a medical standpoint. So there's the psychological distress of worrying a medicine's dangerous. There's the potential issues of just getting lab runs themselves medically. And then there's the financial costs. So if we're not adding value and we have these costs, we should really think, is this a high value practice that we want to be doing? Yeah, so in my practice, based on our Delphi study, I'll offer all patients to check labs. Kind of my default be to check some liver tests and lipid panel at baseline, and then again at peak dose. And if those are unremarkable, to not check any further labs. That's kind of my default monitoring standpoint, just because that's kind of the current standard of care. That's what our Delphi suggests. That's kind of what's discussed in the guidelines. But for those who really don't want to check labs because of the financial costs, maybe they have a very high deductible plan, and that's actually a pretty significant amount of money for them on top of all the other costs of visits and things. For those who really don't like getting their blood drawn, after we have a discussion about the evidence and the risks and benefits of lab monitoring, if they understand those risks and benefits and they'd like to not have lab monitoring, I think that's a reasonable approach to defer lab monitoring after that conversation. I don't think it necessarily needs to be our standard approach, but I do think it should be something that we consider offering to patients when they understand those potential, trade-offs of checking versus not checking labs. Yeah, so historically, people would get labs pretty much every month. So they'd get, a complete blood count, a lipid panel, LFTs, pretty much every month. And our data and others have suggested that that complete blood count monitoring, and the guidelines echo this as well, is particularly low value and probably does not need to be done at all. And so I do think that practice has started to get less over time, but certainly there's still pockets of people who commonly check that either because they believe it's valuable or just because we often keep doing the things that we've been doing. That's a common thing in medicine. It takes a long time for new practices to come in. And I hope that the guidelines will give people more comfort who'd like to change their practice. And maybe just we're waiting for, some better evidence or some better guidelines to help support them in making that change. So that's certainly a practice that's become less, but is still ongoing. And then many people are checking monthly LFTs and lipids. And then there are other people who are doing that more kind of baseline and peak dose type approach. And I think there's a split of different people and doing different strategies. And there, of course, is uncertainty about this. There's not necessarily a right or wrong answer. There's not a one-size-fits-all approach. So it is important to have shared decision-making with patients to help them understand the evidence and to work with them to decide the best approach to their care.